The CME is a bench to bedside approach. Quite literally, we have the lab personnel of pathology and microbiology, and we hope to link it to the clinical side and then have a panel discussion. My topic is quite simple and is entitled, Not All Granulomas Are TB. So the granuloma, as we know, a very short slide to tell you that it's a process of activation of signals in which you have these modified cells. I'm sorry, the pointer's not working. Modified cells which are called histiocytes, which are modified to form epithelioid histiocytes. And these are derived from the monocyte macrophage cell lineage of the hematopoietic system. So in the center, the blue that you see is necrosis, and granulomas that we typically associate with TB are the caseating or the necrotizing granulomas. There was a stage, particularly when most of us who are older here were studying medicine, where when you heard the term granuloma, you'd start on ATT. And this was quite common. You wouldn't even wait to see more in the report, and the patient would just be given a course of ATT. But now we know, with the advent of drug resistance and with all the issues, and plus there are so many newer Western diseases like Crohn's, which mimics TB, which can also have granulomas, and there are newer diseases coming up. And so the reason I chose this title was, yes, we need to know that granulomas are still associated with TB, but not all granulomas are going to be definitively called tuberculosis. A broad, brief classification, as I said, if it's based on necrosis, it's caseating versus non-caseating. Caseating necrosis is a particular type of necrosis which looks like cheese, so it's also called cheesy appearance on the gross. And according to etiology, it can be infectious, for example, tuberculosis, fungal, others. Inflammatory causes such as sarcoid, Crohn's disease, Wegener's granulomatosis. It can be a foreign body granuloma. For example, post-surgery, when you have a suture that remains, that gets incorporated into a granuloma. Certain diseases and certain tumors can be associated with granulomas, like lymphomas. Granulomas can be drug-induced, and finally there's a group in which we do not know what the cause is. So I like this saying a lot. It was a doctor from Maryland School of Medicine who said that, you know, when you hear hoof beats, you think of horses and not zebras. Horses and zebras are quite rare here, but I guess the zebra is as rare here as it is in the US. The point being that when you, especially for the DNB students, when you see common things, please think of the common things first and don't think about the rare things. So that's the caveat to my talk, that yes, not all granulomas are TB, but typical granulomas, such as the caseating granuloma that I mentioned, is almost, so this is a lymph node, and I'm sure that you will appreciate that it really looks like cheese. So it's a particular type of caseous necrosis. All the slides that I'm presenting today are cases that we have seen here. So nothing is from the net. So this is a typical granuloma. I hope non-pathologists will go away not just seeing blue and pink. If I've achieved anything, that would be great. So this pink material is the necrosis which corresponds to this. And the blue, this particular pink aggregate of rounded cells is the granuloma. It's a caseating granuloma, and you will see these histiocytes, these giant cells, which have what's called a horseshoe-shaped nucleus. So it's called a Langhans giant cell, and it is bordered by lymphocytes. So this is a typical caseating granuloma, and almost always this is associated with tuberculosis. Now the acid-fast stain is a stain that we can do. It's a modified, it's a particular stain where we can detect these acid-fast bacilli, but if in the necrotic areas, if you look for it and you find one or two bacilli, it's almost always TB. But this depends on many things, such as the immune status of the patient, whether he's received therapy before for ATT, and of course we know the dreadful nature of drug resistance these days. So for all these reasons, you may or may not get bacilli. And we just wanted to emphasize the reason why Dr. Sunita and I thought of this is, when you get lesional tissue, almost every day we get about, say, 10 gastric biopsies. These are the biopsies we almost always get. About 2 or 3 of them always have the diagnosis of query TB, query Crohn's. Most gastroenterologists do, if they suspect TB, they will send a portion of it to microbiology. But sometimes you don't. And so when you get lesional tissue, you're looking at the ulcer on the endoscope and you think it could be TB versus lymphoma. That particular piece of tissue, if you could please divide and send a portion, even for pediatrics, any specialty, send a bit of it to pathology and send the other bit to microbiology. Most CMEs are meant to educate the public. Here we need to understand, even within amongst ourselves, what tests we have. So Dr. Sunita will be going into detail. But there's a word of warning here. The specimen that we receive in pathology is meant to be put in formalin. If you send Dr. Sunita the specimen in formalin, nothing is going to grow. So this is where we're going to have the nursing perspective also. And it would be really cool if you could just talk to us before you do the biopsy. Just takes a phone call, just tell us this is what we're trying to do. So we'll also follow up with the technician to make sure that there's no errors. Okay. We had a case, this was a case of Dr. Ambika's, where there was a perforation in the appendix. And traditionally, appendicular perforations are quite common. You may or may not see the entropius vermicularis. It's straightforward. But this particular case had, do non-pathologists recognize the same pink rounded collection? So these are still the granulomas, and the entire appendicular wall had these transmural granulomas. Luckily, he had sent a portion of this to microbiology, and I think it came out to be TB positive. So it's very nice that we had this correlation in this particular case. And he had a perforation because of TB, no primary lesions elsewhere, nothing else in the gut. So just to indicate that we still have primary TB intestinal cases in India, which is, it's not a good thing to happen, but we still have it. So the main thing in gastroenterology that we encounter in the lab is it TB and is it Crohn's? A couple of decades ago, Crohn's was known to be a Western disease, and it did not happen in India, and there were very sort of stringent criteria. You'll see the nice, well-defined granuloma in Crohn's. You'll see a granuloma which is about 400 microns. But unfortunately, Mycobacterium tuberculosis does not read textbooks. It just doesn't. And we almost never see prototypical lesions. That's mainly because patients might be suppressing a history of drug history. They may be having associated other conditions that they're not telling you about. And so because of these reasons, we may never see. But all the slides that I'm projecting here are slides that I've seen in the last 2 months. So that's the volume of material we have here. So this is a colonic biopsy, and the ulcer is quite superficial. And you see these pale histiocytes here. The traditional ulcer of Crohn's is supposed to be a deep ulcer with stricture, but I think Dr. Soman will tell you that sometimes strictures do not necessarily mean it's only Crohn's. You can get stricturing also in TB, and I know that there's an emergent variant where you get both together, tuberculosis and Crohn's. So this, what we call naked granulomas, which do not have necrosis, this was a case of Crohn's disease. So this is one of my colleagues, Dr. Anna Pulimud, Ansu. She had published in 1999 a gut seminal paper, and they followed it up by this. So again, just to reiterate, the textbook criteria, granuloma more than 400 microns, superficial, with caseation. And if you see granulomas in the cecum, it's almost always TB, never going to be Crohn's. And similarly, if you see cryptitis or architectural changes with granulomas, most likely to be Crohn's. There is an overlap, and we can't always go by this. So it's so nice when we just go across and check in microbiology, was a TB PCR done, particularly for cases which are TB not responding to ATT, or Crohn's not responding to things, then you know that there might be a shift in the change. The other less common cousin of Mycobacterium TB is Mycobacterium leprae, and acid-fast bacilli seen in Mycobacterium leprae are seen in the tuberculoid variant, which looks like typical TB granuloma, but it's present in the skin, and but generally you do not see so many acid-fast bacilli. Now coming to tumors which can have granulomas, notoriously lymphomas, and amongst them Hodgkin's disease. So you may recall from your undergraduate days of what a RS cell looks like, the owl-eyed nuclei, and you see granulomas on this side. So if you get a lymph node, or if you get the entire lymph node and you see your RS population, mixed cellularity, and you see the granulomas, that's fine. But what if you get a true cut biopsy? Supposing you have a mediastinal mass and you have a true cut biopsy and all that you see are these. Now, the clinical presentation is identical, right? Generalized lymphadenopathy for both, whatever the symptoms are, they'll be the same for TB and for lymphoma. So it's so important to note that the treatment of lymphomas is sometimes delayed because the patient starts immediately on ATT. The lymphoma is suppressed, only to come back later. So these are the issues we have. So that's why not all granulomas are TB. You must always consider differentials also. And the TBs, the lymphomas, the granulomas and lymphomas can also be necrotizing. And we know that you can get TB and lymphoma together. And Pritish can tell us the rest. And there are two types of granulomatous lesions, lymphomatoid granulomatosis and granuloma annulare. So when you get skin biopsies, the entire thing changes. Don't think TB immediately when you get skin, because you very rarely get fistulas and all. You must consider other granulomatous lesions. And we had this rare case recently where an orchidectomy was done. The initial slides had nice granulomas. There were some areas of germ cell hypoplasia. And anybody except the pathology PBs, can you identify what this is? This is testicular in the region of the testis. So these are adult worms of filariasis. So again, TB looking granuloma in the presence of filariasis. So I'll end my talk here. Again, please note that all granulomas are not TB, but when you hear hoofbeats, please think of horses and not zebras. So think of TB definitely when you see caseating granulomas. And when you have lesional tissue and you have enough material to spare, please send it to both micro and pathology. Do not send the formalin dunked tissue to Dr. Sunita. She will not be able to grow anything. And reversely, don't send us at 7 o'clock something which does not have formalin, because we won't be able to. So please educate your team, and especially nursing, All the nursing and the lab medical staff should have a rotation in pathology and microbiology. Thank you.
A very good afternoon to the August gathering, and I'm really happy to see such a nice gathering today, and all credit goes to Rekha ma'am. And on this World TB Day, ma'am told about granulomas. So from microbiology perspective, I will be telling very basic things. I will be mainly concentrating on the very basic like IGRA and Mantoux, because lots of confusion revolves around IGRA and Mantoux. Which patients to be conditioned for Mantoux and which patients should be conditioned for IGRAs, and how to interpret the Mantoux and IGRA. And then I will just touch upon how important it is to send cultures when you are thinking of tuberculosis to the microbiology department, starting from the basics like IGRA, Mantoux, to AFB smear, culture, and molecular detection. Because if these things are not done parallelly, somewhere we get lost. Because to start my first slide, when I went through the India TB report of 2024, the total TB patients has jumped to 2.55 millions in 2023, and MDR, rifampicin resistant TB patients which were notified were around 63,939, which is quite alarming. So TB disease is a leading cause of infectious disease with morbidity and mortality worldwide. and it has got many diagnostic uncertainties. So this is where we get stuck. So going forward, I will just present one case here. A 2.5-year-old boy with fever and cough for 3 weeks, tachypneic. Sorry. Yeah. And had bronchial breathing with crepitations in the right inframammary region. The blood picture showed anemia, lymphopenia, neutrophilia, and ESR 30 millimeter at the end of 1 hour. So there was definitely a suspicion of TB. So the sample sent was gastric lavage from the patient when the patient was fasting. And around 50 ml was sent to the laboratory, and M10 CB-NAT detected MTB with rifampicin and INH sensitive. So what I want here you all to understand is that when we are suspecting TB, we should choose the right test. So suppose the gastric lavage is not sent, and we beat around like Mantoux and IGRA and ADAs, then somewhere we get lost, because interpreting Mantoux, IGRAs and ADAs sometimes becomes very confusing because of the nature of the patients when we are dealing with. So going to the next case, a 58-year-old male who was suffering from hairy cell leukemia, and was treated in other hospital and was referred to our hospital for blood culture. So we injected, the blood was sent to the blood culture bottle, and we incubated in the automated blood culture machine, and it flagged positive. So it was in the month of December. The time to positivity was 86 hours. We calculate the time to positivity in a blood culture bottle in order to know what is the load of the bacteria. And then we did a gram stain and subculture it on McConkey agar and blood agar. On gram stain, we found gram-positive bacilli. So to tell the audience, I want to tell that when a blood culture comes positive, usually we see gram-negative organism, because we think that the patient must be having a gram-negative septicemia. And when we get a gram-positive bacilli on gram stain, we usually neglect it and say that it could be a skin contaminant because bacteroides and all. But what happened, this gram stain was beaded bacilli, gram-positive beaded bacilli, so which gave a clear suspicion that it could be a TB bacilli. So what we did a ZN stain. We did a ZN stain, that is AFB, and then AFB was positive. Okay. Now, to get a AFB positive in a blood culture bottle is very rare. But we got it. It always, I would like here to tell the audience that when we get a TB bacilli in blood, it is always a non-tuberculous mycobacteria, which is not a typical Mycobacterium tuberculosis. So these things should be kept in the mind of microbiologists and also to the clinicians, that when we receive blood culture, we should also follow up, and at the same time, clinicians also should follow up that what is the bacteria that you got from the blood. So this was an eye-opener, and then we saw AFB. Well, here I would like to say that as soon as we saw in AFB stain that there is AFB bacilli, we subcultured it into a solid media and also a liquid media. Now, it is very important because TB bacilli takes a longer time to grow. So that is why if you do not do parallel cultures and other things, then somewhere the time gets lost. So here we did a liquid culture and a solid culture. Since it was a non-tuberculous mycobacteria, the growth came in 4 days. And once the growth came in 4 days, this is just a WhatsApp message that I got from sir, and he asked that, we asked patient what treatment is the patient getting. So patient was on gram-negative, patient was treated in the line of gram-negative sepsis because of hairy cell leukemia. But then since it was a non-tuberculous mycobacteria, the whole treatment module changed. So this is something which should be kept in everybody's mind, that this could happen to people who are immunocompromised. So, coming to the other investigations, when we get a pleural, cerebrospinal fluid, ascitic and joint fluids, so these all tests should be done like cell counts, ADA, IGRA and AFB smear microscopy. Then, as I told that, very simple test like Mantoux, that is tuberculin skin test, it detects cell-mediated immunity to Mycobacterium tuberculosis. It is a delayed type 4 hypersensitivity. Purified protein derivative is used and it is given intradermally. I have written 5 TU because for pediatrics 5 TU, for adults it is 10 TU. So these all things should be kept in mind who all are doing the TSTs. Now, interpretation, if it is 5 millimeter, we have to interpret if it is 5 millimeter for close contacts of tuberculosis, immunosuppressed patients, and if there is clinical and chest X-ray evidence of current or prior TB and persons receiving TNF blocking agents. And more than 10 is significant for persons born in high TB incidence countries, that is more than 20 per lakh population, and patients who have occupational exposure to tuberculosis and patients with medical risk factors that increase the probability to progression. Now 15 millimeter or more for other. Now, false negative reactions also should be kept in mind. For infants and young children, we can get a false negative. Persons who are recently having viral infection, HIV infection, disseminated tuberculosis, and immunosuppressive drugs. Now, when do you have a Mantoux positive? This is very important to understand that Mantoux is a PPD. Okay. Now, it is an in vivo test. So, Mantoux will come positive in three cases, that is in TB infections, in BCG vaccinated individuals, and also in non-tuberculous mycobacteria. So now it becomes very difficult. Suppose the Mantoux is positive, now we do not know whether to give, if the patient is Mantoux positive, we do not know which treatment to start. Should we start AKT or should we start a non-tuberculous mycobacteria treatment? So now this is the time when the IGRA is important, because IGRA, that is TB Ferron or gold, the TB gold which test you all sent. Now IGRA and TB gold are very specific to Mycobacterium tuberculosis because they do not cover non-tuberculous mycobacteria. So this is the difference, that sometimes it is a debated topic that should Mantoux be done? Is Mantoux a wasted test? Should IGRA be done? Is IGRA a wasted test? No, both are not wasted tests. Both have got their equal clinical implications and both have to be understood to which patients we should do Mantoux, to which patient IGRA should be done, and once it comes positive, how it is to be interpreted. Okay, now since we are talking about Mantoux test, a new Mantoux test, that is tuberculin skin test, has come from the Statens Serum Institute, Copenhagen, Denmark. The challenge of the Mantoux test was that it included 3 types, like Mycobacterium, non-tuberculous, and also BCG vaccinated patient. Now this new test will have the advantage that it will be specific to only Mycobacterium tuberculosis and it will not be confused with other BCG and non-tuberculous mycobacteria. It can deliver IGRA-like performance and uses universal 5 millimeter cutoff to differentiate the infected from the non-infected. The test is based on ISAT-6 and CPF-10 antigens, which is specific for MTB, and it is unaffected by BCG vaccination. So this is the new test that we will be getting in the near future. Now coming to IGRA or TB Ferron or TB Gold, it is a delayed hypersensitivity, but it is an in vitro test and it detects interferon gamma release. And we combine the blood of the patient with the TB antigen, and ISAT is the early secreted antigen 6 and CPF is the culture filtered protein 10, but it is not PPD. So that is why it has got an advantage over Mantoux. Okay. Now, should an IGRA or a TST be performed in individuals who are 5 years or older? Yes, it should be performed, but it has to be kept in mind that IGRA has got a sensitivity of 81 to 86%, whereas Mantoux has got a sensitivity of 71 to 82%, which is lesser than IGRA. Now, second question is, in patients who are known to have received vaccination with BCG, should IGRA be done? Yes, because specificity of IGRA has been superior to Mantoux or TST. Should an IGRA or TST be performed in individuals 5 years or older? Yes, it should be. Now, coming to a very rare type of tuberculosis, that is Mendelian susceptibility to mycobacterial disease, I'll present a case. It was a 12-year-old male who presented with headache, vomiting, and 2 episodes of seizures, but had a past history of receiving ATT twice at the age of 7 for BCG adenitis and age of 7 years for cervical lymph node TB. But without any microbiological diagnosis. Now, he had a history of recurrent infection like salmonellosis. He had a history of 2 episodes pneumonia requiring hospitalization. So, to sum up the history of the patient, it seems that the patient is having recurrent infections, prone to recurrent infection. So, this is what is known as Mendelian susceptibility to mycobacterial diseases. Now, when the patient presented with seizure, the CT scan report was like this. CSF was therefore done, but proteins and sugars did not indicate anything. MTB was not detected. Multiplex PCR was negative, culture no growth, toxoplasma negative, cysticercal negative, beta-D glucan and galactomannan negative. So whole plethora of the tests were negative. Now a biopsy was done and this is nocardia. Okay. So what I mean you all to understand is that proper sampling is very important. If proper sample comes to the department, we can clinch the diagnosis and give the proper treatment. Now, patients who are suspected to having pulmonary tuberculosis, so we need 3 specimens, volume should be at least 3 ml, and we usually require to do a acid-fast smear microscopy. We also need to require mycobacterial culture both in liquid and solid medium because liquid growth is faster. We need to do a NAT, that is nucleic acid amplification test, which we have M10 in our hospital. And the interpretation is if AFB is positive and NAT negative, then it could be NTM. But M10 in our hospital detects both MTB and NTM, so there is no confusion there. Now, if it is AFB negative and NAT positive, we should do a molecular drug susceptibility testing. And if it is liquid and solid mycobacterial cultures, we should also do a susceptibility testing for those. Now, to conclude, preventive vaccines are there, but it is only 40% effective. And bacteriological diagnosis of TB is essential for the treatment of tuberculosis because we have to treat either MTB or NTM, and both the treatments are different. So that is why we have to understand and we have to do a culture. Now, CB-NAT is essential for TB diagnosis in order to understand whether it is MTB or non-tuberculous mycobacteria. Correct specimen collection is very important because if we do not have correct specimen, again we will not have proper diagnosis. Now, role of XDR panel and gene sequencing is the need of the hour because we, as I said before in my first slide, that the amount of MDR and rifampicin resistant tuberculosis is on the rise. And indiscriminate administration of antibiotics can lead to dangerous MDR. So that was my last slide. And thank you all. And my deep acknowledgements to my department and the infection control department. Thank you all for your patience here.
We are celebrating World TB Day on 24th of March every year. And I think in 2023 also we celebrated it in this hall. And now again in 25. So this year's is, yes, we can end TB, commit, invest, and deliver. So there is a lot of stress throughout the world to control TB and in India also. So the purpose of today's meet is to bring about awareness, and all the specialties should unite to end TB. So that's why we have a panel discussion among all the specialties. Now, this is a review article from Lancet for this year's World TB. Tuberculosis is the leading cause of death globally. It's airborne, so everyone can get it. Anyone can get it. High incidence settings are more exposed, so India is still a high incident country. Risk of progression of disease is higher in immunosuppression and diabetics, and then the transplant group. So a lot of immunosuppressants we use, so we will come across a lot of TB patients. Classical presentation of TB is cough, fever, weightless. But remember, you can be completely asymptomatic also. Prompt diagnosis can be made from sputum examination for pulmonary TB, but others you have to depend on other things. So that's why our pathologists and microbiologists have given an idea how to diagnose TB from other tissues also. Chest radiograph doesn't confirm TB. It only gives you some idea it could be TB. And most people with disease can be treated with 6 months regime. So that is the good thing about it. But then for successful treatment, a comprehensive person-centered care of comorbidity is necessary. See, India is a capital of diabetics, so that's the main group. I told you a lot of immunosuppressives are used, that's the main group, so you have to be very careful. And prevention relies mostly on treatment with rifampicin-based medicines. So most of the white TB duration has shortened down and it has become easy because we have rifampicin group of drugs. So any regime with rifampicin is important, and that is why in a molecular testing we check for rifampicin sensitivity. That is important. Now, overall, we suspect clinically. Again, get an idea from radiologically, but for confirmation, we have to have a microbiological or a histopathology. Microbiologically, just AB staining, ZN staining will give you hardly 20% from pulmonary TB. But if you go for molecular testing, it's as high as 70%. So that's why this has become the national program. This molecular testing is freely available throughout the country now. Histopathology, again, is the next. What is important is, apart from pulmonary TB, around 15 to 20% are extrapulmonary TB. And that is where all the other departments come in. Lymph node and pleural is most common, but you have TB from head to foot, all the places. And what Madam was telling about CBNAT, you see all tissues do not have so much sensitivity in CBNAT. CSF is good, but other tissues like pleural fluid, ascitic fluid, or lymph node, CBNAT is not as good as pulmonary samples. So with this, I call upon Dr. Sushant Sethi to give his presentation, and then we will sit down in the panel.
Very good afternoon. At the outset, I am thankful to Dr. Rekha, Dr. Sunita, and whoever has organized this. So my job is to tell intestinal tuberculosis versus Crohn's. So TB versus Crohn's, what Dr. Rekha meant, usually I understand that intestinal tuberculosis versus Crohn. So, as you all know, intestinal tuberculosis is caused by Mycobacterium tuberculosis, which primarily affects the lungs, but can also involve the intestines. But in contrast, Crohn's disease, which is a chronic inflammatory bowel conditions of unknown etiology with possible genetic, environmental, and immunologic factors. That means, in a genetically predisposed individual, there occurs some environmental insult, which in the form of infections or some other form, we don't know, that's the reason the etiology is unknown. There occurs some changes in the gut or intestine, there causes ulcerations, and we see it is as Crohn's disease. So historically, tuberculosis is a disease of poor, but Crohn's disease is a disease of rich. maybe 15-20 years down, we are not seeing more of Crohn's, we are seeing tuberculosis only. Nowadays, we are more recognizing Crohn's disease. Why is it so? More likely, the incidence has gone off, but second, most importantly, earlier people are not able to recognize Crohn's. The awareness was not there. The pathologists we are also not aware about Crohn's, so also the clinicians. So probably nowadays we are getting more Crohn's. So, but as I said, historically tuberculosis is disease of poor and Crohn's is a disease of rich. And you talk about hygiene hypothesis and all other issues we might be discussing later. So, if tuberculosis has to choose a person, it might, choose me. But in contrast, Crohn's will choose rather Vikas Bhai or Raja sitting in front. So, clinical presentation includes shorter history, less than 6 months for tuberculosis. Constitutional symptoms in the form of fever and night sweats, pulmonary symptoms, peritoneal disease, and abdominal lump. So they are best typically for tuberculosis. And in contrast, Crohn's disease, there occurs longer durations. The duration is longer. Sorry. The duration is longer. Chronic diarrhea is there, hematochezia is there, perianal diseases are there, extraintestinal manifestations are there. But then, there are some features they share in common. What are they? Abdominal pain, intestinal obstructions, weight loss and anemia can be shared both by tuberculosis and Crohn's, so that one disease can become indistinguishable from other. Once we are not able to identify something by clinical means, we have to rely on the lab, radiology, pathology, etc., etc. That is the reason without them we are handicapped. So if you talk about histopathological features, basically in Crohn's, the granulomas are less commonly found in comparison to intestinal tuberculosis, and the size of granuloma are bigger size. They are well formed, confluent granulomas, and with greater giant cells, and locations are usually submucosa. In contrast, the fibrosis stricture, they are more common, and fistulas, they are more fissure and fistula, they are more common in Crohn's disease. Because Crohn's is a stricturing disease, a subset of fibrous cytokines, they causes ulcer, later on they lead to stricture. So you get fistulas, fissures, because it's transmural involvement. Because if it is intestine, whole of thickness of the intestine is involved in case of Crohn's. That's the reason you get more fistulae, fissure, abscess, and other things in Crohn's. Also best line by histiocytes, obviously common in tuberculosis, not common in Crohn's. I mean, that's not found in Crohn's. And lymph node granulomas without intestinal involvement, that is commonly found in tuberculosis, but rarely can be also seen in Crohn's. We had seen patients of our patients, lymph node granuloma in Crohn's also. So this is the histopathological features. Now the radiological features. So the Crohn's disease, the long segment thickening, skip lesions, pseudosaculations, comb sign, left colonic involvement, they are common in case of Crohn's disease. But in contrast, in tuberculosis, short segment ileocecal involvement. The ileocecal is involved in both Crohn's and tuberculosis, but the ileum site is more involved in Crohn's, and cecal site is more involved in tuberculosis. And second, the tuberculosis is the only ileocecal part is involved. In Crohn's, the whole of the colon might get involved. Necrotic lymph nodes, active TB on CT chest, if you are getting, so they will point for more favor towards tuberculosis. Coming to the endoscopic features in longitudinal ulcers are more common in case of Crohn's disease, but transverse ulcers, they are more common in case of tuberculosis. Similarly, cobblestone appearance, the patulous ileocecal valve, rectal involvement is more common in Crohn's, but rectal involvement is not common. GI bleeding, perianal bleeding, they are not common in tuberculosis. And so that is the endoscopic features. So treatment, and we all know, tuberculosis it should be treated by ATT for 6 months. That's it. But in contrast, Crohn's has a complex treatment. The treatment is not simple. Patient require treatment for lifelong. What are our aim? It primarily involves medications to reduce inflammations, manage symptoms. Nowadays, we are talking of mucosal healing and targeted therapy by biological therapy and other therapy, which includes steroids, immunosuppressants, biologicals, small molecules, endotherapy, and surgery. And please remember, the treatment of Crohn's is for lifelong, but treatment of tuberculosis is a finite duration, which is usually 6 months. So what are the take-home messages? As I said, significant overlap of symptoms between TB and Crohn's. TB is a disease of less than 6 months duration, but Crohn's takes a longer time to be diagnosed. Endoscopically, no exclusive features. Histologically, large, confluent, cageating granuloma seen in tuberculosis. If you are getting in histology A, B, your diagnosis is done, job is made. And imaging-wise, necrotic TB lymph nodes are more common in tuberculosis, and chest findings, if you are getting some chest lesions, then the tuberculosis is more likely. And in long segment involved plus involvement plus visceral fat analysis by subcutaneous fat ratio, this is the new technique we developed in ultrasound, so that is helpful in CD or Crohn's disease diagnosis. PCR may not be considered as standalone diagnostic testing for intestinal tuberculosis. Gene expert, very specific but low sensitivity. IGRA, Mantoux, supportive but not definitive. We might discuss regarding more about these in panel discussions. So TB and Crohn's are like this. So sometimes CD camouflages as ITB and vice versa. But if all sides are there, I mean, as you can see the eyes. If A, B you can see, then yes, you have clicked. Otherwise, you will have difficulty in diagnosis. This is why it is recommended that if you are in diagnostic dilemma, in confusion, whether it is tuberculosis or Crohn's disease, that is recommended that we should give ATT for at least 1 month. Then we wait for the response. If not, then we will revise our diagnosis. But in contrast, the reverse is not true. We should not start treatment of Crohn's disease because it involves immunosuppressants, biologicals, and other treatment. The chances of tuberculosis will be flared up. So this is it. Thank you, everyone.
Dr. Sushant, Dr. Bhubaneswar has a presentation, so after he finishes, we'll go to the panels.
A very good afternoon, and thank you, Rekha, for this opportunity. And basically, we've already discussed about the main tuberculosis and its diagnosis, and also I'll hit directly to where my topic is, and that is tuberculoma. So basically, we'll discuss in short the diagnosis, which is already, most of us have already heard from them. So it will be the radiology where it confuses the most, and what is the surgeon's perspective. Now, tuberculomas are basically granulomatous masses which arise out of mycotuberculum tuberculosis infections. But these are quite common infections in the CNS, and they may present as solitary or multiple lesions and can mimic a variety of lesions together. And always reaching the diagnosis becomes a Herculean task. So what are tuberculomas? Tuberculomas are basically conglomerate caseous foci within the substance of the brain, and they develop within deep-seated tubercles acquired from recent or maybe a remote period of basilemia. Usually, diagnostic studies, MRI and CT are the mainstay of the investigations, and usually a target sign which shows a ring enhancing lesion all around are clinching the diagnosis of a tuberculoma. But as easily said, this is not the case. When you see, sometimes the picture of a tuberculoma looks like this when you get the first sign. And only after a proper imaging with the gadolinium enhancement, it looks like a tuberculoma on the right side. So it's very difficult to diagnose radiologically, and many a times the help of sometimes PET CT also helps. However, with all this also, many a times tuberculomas go undetected. So here comes the role of MRS. So with spectroscopy, a lot of chemicals are analyzed in the scan, and with lipid lactate peaks, you can still clinch the diagnosis to a tuberculoma, though this is just an addition to the MRI. Histopathologically, already as discussed, the biopsy is the mainstay of the diagnosis. So once the biopsy is taken, it yields the tissue, and that gives us the information of the AFB positive bacilli. These are the few symptoms which usually are there when a tuberculoma present directly to the surgeon. So what happens is, usually patient comes to the neurologist as a case of headache or presents as a seizure with some focal neurological deficits, and sometimes with raised intracranial pressures, and these also may mimic all these signs of a brain tumor pathology. So always a confusion of brain tumor exists with tuberculoma. So if you see, the one on the left side is a case of tuberculoma, and you see on the right side, this is a case of brain tumor. So hardly there is any distinction, and it is very difficult radiologically to diagnose these as tuberculomas or brain tumors. And this also can, the same similar pictures can also show in metastasis. So when we get these patients, the first and the foremost is sputum cultures. But as in pulmonary TB, the sputum cultures may identify the tuberculosis. But for tuberculomas, most of the times the sputum cultures are also negative. And with complete array of all tests, active pulmonary tuberculosis may not be seen or it may not show, but still tuberculoma will exist. So that is the basic difficulties to diagnose, because all the tests of tuberculosis comes out negative. So then finally we come with either we have to do a CSF analysis, and with CSF analysis also it is not a very easy thing to get to the diagnosis. Many a times only the CSF analysis shows elevated protein levels, and sometimes we get CSFs with isolated tubercular cells or some granulomatous tissues, but very rarely you get diagnosis just from the CSF. But analysis through molecular testing like PCR and gene expert, these are the tests which may give you a diagnosis, but still these are also not very conclusive. And to make things worse, these patients always have some immunocompromised conditions, usually in cases of HIV, or these patients also have fungal abscesses. Many of them also have bacterial abscesses. So it's very difficult to distinguish between all these three things. And usually in immunocompromised patients of HIV, coexistence of diabetic mellitus. So all of these coexist. So again, the diagnosis becomes difficult. So the basic, what we differentiate is between the tumors, the brain abscesses or the fungal abscesses. But when all of these still give you a place where you do not have anywhere else to go, we have to go for the stereotactic biopsy, which ultimately yields the tissue, and then when we send it to the histopathologist, we get the final diagnosis, because that is the ultimate. Once you take a stereotactic biopsy, or if it's a surface lesion and you do a small craniotomy and take the tissue for biopsy, that is when you get a final diagnosis and stamp it as a case of tuberculoma. Sometimes surgery is mandatory for tuberculomas. Usually a tuberculoma, if it is diagnosed, then medicinal treatment does take care of it majority of the times. But there are few guidelines where surgery is required. So surgery is mandatory if the tuberculoma is larger than 20 mm, or if it produces a huge mass effect and is endangering eloquent area of the brain, or else it becomes an emergency if there is elevated intracranial pressure. And last but not least, when already medical therapy has been given and still the tuberculoma is not, because many a times what happens because of the blood-brain barrier and the tumor becoming, the tuberculoma making a space where antibiotic and anti-tubercular penetration to the tissue becomes a issue. So there medical therapy fails. In those cases, we need to do a surgical excision and remove the tuberculoma. But given the rarity and the potential for misdiagnosis, always a multidisciplinary approach involving all the neurologists, the infectious disease specialists, the pathologists, the microbiologists, and the radiologists is very essential to optimally manage the tuberculomas. That will be all. Thank you.
Classical teaching of fever, evening rise of temperature and lymphadenopathy, though in true terms goes in favor of a tuberculosis, but just don't sit over it. Maybe you need to explore it to other aspects of the medical sciences. Second patient again was a case of rheumatoid heart disease, a lady who came with a fever for 3 weeks, and then patient was admitted, had seizure and left hemiparesis, and patient had a lesion, ring lesion lying there, and we almost forced Dr. Vishwal to go for a surgery, and then he removed it and it came out to be melioidosis. So I'm saying that even that it was a classical tuberculoma, radiology picture was fitting into that. The radiologist also gave the opinion that it's a tuberculoma. There was a lipid peak and all that, everything was there. But when it was explored and sent to the lab, it came out to be something else. So my say is that just the earlier teaching was, the standard textbook teaching might not go well in every case. It can vary from case to case. And there are various other examples also. But yes, histopathological confirmation is the gold standard, and wherever it can be achieved, one should always go for it.
Thank you. The only other point I want to make is CNS tuberculosis, the treatment is 1 year, not 6 months. Okay.
Sir, 1.5 years. It is 18 months. Bone and I think bone and brain.
CNS.
It is 18 months. Though ICMR has said it for 1 year. ICMR itself has shown it's 1 year. But all other guidelines, everything is in favor of 18 months.
No, see, classical was we were treating for 1.5 years, 18 months. But now, the last 5 years, the recommendation is 1 year is enough. We don't.
More than 1 year, and depending on the response and clinician's choice, it's more than 1 year. After that, you decide how much time you want to go.
Okay. So next, because Sushant has already taken up that talking, so we'll go to the gastrosurgeon, Dr. Somen. Anything you want to say about tuberculosis or anything else?
I actually want to say already, Sushant sir has been told the extrapulmonary TB consists the most, around 1/3 of the TB. And out of that, abdominal part is the most common. And from them, as you told, lymph nodes presentation common. I will just tell whatever recently, last 5-6 years come up HPB, that liver, pancreas and biliary part. They are also rare forms of TB. Whatever everybody may be seeing in the clinical as a gastro and liver, all may be seeing. Nowadays, liver is the most common. As per the PubMed literature, 2007 from AIMS, they have published 20 years experience, only 18 to 20 odd cases of documented HPV TB. So it is very, very rare actually. And most common site is primary TB. I am not talking about secondary. It is very common miliary fermentation, like splenic and liver diffuse nodules. But primary HPV TB are very rare, but it should be kept in mind. Like liver, there will be presentation like liver pseudotumor. Any CLD cases, cirrhotic nodules, dysplasia nodules, we take the help of radiologist and pathologist also. Like in our last 2 transplant cases, we are finding granulomas. So it's still, we don't know what is sarcoid or it is nodules, not fitting into clinical picture. So pseudotumor presentation is a common form of liver TB. Coming downwards, GB. That is in our Gangetic, our Odisha belt, CAGB is very common. So such a presentation comes with GB mass. Initially ultrasound there will be GB mass and there will be extra serosal infiltration like colon, biliary duct, liver. So first of all everybody will think 90% or 99% it is a CAGB. We rule out CAGB from radiology and biopsy, and then if there is suspicious, like more common presentation we are seeing in old age, like 50s, 60s, diabetic, thyroid, there is a presentation as called as xanthogranulomatous cholecystitis. And it is a pathological diagnosis where you can find Langerhans giant cells and granulomas. We don't know, never find like textbook AFB positive, but it is a post-operative diagnosis. So pre-operatively, one should keep in mind that GB mass can be presentation as xanthogranulomatous we still don't know TB. In some case reports, TB AB is positive, but majority they go by like xantho presentation. Second, coming down, biliary strictures are also presentation of TB. They present like PSC or certain strictures where if certain bile culture, sometimes very rarely AB can be positive, but even if you empirically give ATD, there is worsening of jaundice also because they form a fibrotic stricture. That is also a clinical dilemma because no studies are there, only case series case reports. And coming down to pancreas, which is very common, a common presentation with jaundice, pain abdomen, ultrasound, C head of pancreas. You do CA99, maybe ambiguity, there will be positive. You do PET scan also, both malignancy it is positive, in both TB it is positive. But I want to comment that in recent years, one FAPI PET has come up to differentiate stricture, sarcoidosis. They are more directed towards like cancer derived fibroblast. They pick up more cancer differentiation. So in TB, we see like heterogeneous mass with more lymph nodal presentation. So certain, not a single decision is taken. We take the help of radiologist, gastropathologist, interventionist. Then we decide, come up that, okay, we go in favor of TB, we take biopsy. And then after multidisciplinary decision, we go for surgery, explaining the patient, okay, 5-10%, it will become as benign in HPP. Thank you.
So in abdominal TB, ascitic is most common, and then lymph nodes and other things. And recently, I have got a lot of cases from the oncologists. They think it's probably malignancy, lymphoma or something. They go and do a biopsy, and it comes out to be tuberculosis. So I get a lot of referrals from oncology because the biopsy shows granuloma, I mean, tubercular granuloma. Okay. So next, we go down to Dr. Samiran, genitourinary tuberculosis. When I was waiting for the seminar to start, I got a call from someone, my wife has got genitourinary tuberculosis and she has developed ATT complications, so he wants to meet me today evening. So genitourinary tuberculosis awareness is coming up. Good.
Sunita madam, the urology we see most of the time clinical suspicion only. The samples collection is a big problem, and which sample to give, and these AB versus PCR yield. Then next thing is, now I'm finding, though my suspicion is more stronger, we get a lot of AB positive. Now I'm finding we usually get asymptomatic this WBCs on these patients. But now I'm finding WBC numbers are normal, but they are AB positive. Sometimes I question myself whether these are the ABs to be treated. But some of the patients, after treatment, they got better clinically. So I'm not sure, because WBC, usually we see that there should be higher in these type of patients without any bacterial infection. The other clinical dilemma comes, they are usually masked by recurrent E. coli infection. You will see patients, mainly females, with recurrent E. coli, the underlying cause would be TB. What is your opinion about the sample and the test we should go for?
Good.
Regarding sample, I think the report which we made, no? The student had a study on sampling of urine for detecting tuberculosis. So there, this study detected that 12 hours urine is an ideal sample which is to be sent to the department. And no doubt, NAT, that is nucleic acid amplification, or PCR that you tell, that has got a higher sensitivity than just AFB smear. That is the answer for the second question. And third, which you told that maybe the number of pus cells in the urine may be less, but bacilli may be positive. That is true for sputum also. For lung tuberculosis also, normally we have read that the sputum must be loaded with pus cells and then the TB bacilli comes positive. And that is the reason why we do a Bartlett grading for the sputum samples. Bartlett grading tells us if the pus cells is more, then you go ahead with the TB bacilli staining. If the pus cells is less, you ask for a repeat sample. But we have seen that with less Bartlett grading also, when the pus cells are normal, very less, epithelial cells are more, we get a TB bacilli positive. So depending upon the clinical condition of the patients, whether he is able to produce that amount of WPCs as a reaction for the TB bacilli infection. We have to judge clinically also and microbiologically also.
When this study, we found even AB negative and PCR
Positive, yeah, because sensitivity is high for
That
PCR.
is-
That is why we tell that you give PCR.
What is the chances of non-mycobacteria coming from the urethra or from the bladder?
No. Non-tuberculous mycobacteria, yeah. Yes. Non-tuberculous mycobacteria, let me reiterate here that any tuberculosis, whether it is typical or whether it is non-typical, it is not a contaminant. First, we have to really be sure that it is not a contaminant. Why? Because, contamination may come from the water which we use for cleaning the slides. But we test the water with which we clean the slides. Initially, when the hospital started, that was in 2010, we got lots of TB bacilli positive in the slide. So we did a TB screening of the water which we are using for cleaning the slides, for washing the slides. So that came positive. And we had a disinfection of the loops, and then the TB bacilli came down. So that is the reason why, as an infection control protocol, we do a screening of TB bacilli, screening of the water supply of the whole hospital. So in the present day, any type of TB bacilli detected on this slide is quality checked. So any bacilli which is present on this slide cannot be a contaminant unless and until proven. So that is why all the quality checks are done on a routine
Usually when we
basis.
ask a patient to go for this test, our clinical suspicion is very strong.
Yeah.
Other question is, when these patients are already had some antibiotic and long-term antibiotic, how it affects your yield of the test? That is what also my question is.
For mycobacteria, antibiotics will not treat.
Because most of the
Mycobacteria
quinolones,
persist.
Quinolones, aminoglycosides, because aminoglycosides we see,
That is
use
NTM,
for,
no?
for UTI, E. coli UTI, we use
very commonly we prescribe
quinolones and
quinolones.
aminoglycosides. They are all anti-tubercular.
Sir, sir, for non-tuberculous mycobacteria, fluoroquinolones are active. But for MTB, INH, rifampicin, pyrazinamide, ethionamide is active. So that is why NTM may get masked.
But these two drugs, as sir
Yeah,
said,
aminoglycosides.
they are both
Aminoglycosides
bactericidal
and
also,
quinolones.
bacteriostatic also.
They are all anti-tubercular drugs. So if we are suspecting
That is the
tuberculosis,
problem
we
with us
avoid
as a
these drugs as antibiotics.
Even we sometimes strongly suspect TB, they don't come as positive. That's a possibility because
That
as
will be
because of long-term use or short course use before the sample giving. Though we don't face so much of biopsy problem with the TB in bladder, but the other problem comes. Those are immunocompromised, even because and Devata said that those who basically prostate abscess. We have here also there are 4 or 5 patients. We found them as a TB positive. So there, this is a possibility, atypical or non-MTM. So, but they can actually get effect both. Antibiotic can affect both.
Thank you.
Okay, thank you, Samiran, and thank you, Sunita. Deepa, your take for uveitis or TB?
As far as ocular TB is concerned, TB can affect any part of the eye, starting from the eyelid to the cornea, conjunctiva, the sclera, and the optic nerve. But the most common manifestation that we see in tuberculosis is uveitis. So it's mostly due to hematogenous spread. So it's basically a secondary presentation. So it gets carried through your blood, and since the choroid is the most vascular layer, you see the spillover uveitis. So patients would present with loss of vision and lot of pain, for which they have to be symptomatically treated. But when it comes to diagnosis of ocular tuberculosis, it is even more difficult than diagnosing systemic tuberculosis, because sending samples from inside the eyes, like aqueous humor or vitreous, is far more difficult than getting a blood test done. So that is the reason why diagnosing ocular TB is more difficult, and generally it is done in conjunction with other symptoms that we see, like positive skin test or the chest X-ray signs, and patient presenting with uveitis. So basically clinicians presume a diagnosis of ocular tuberculosis in these settings, and the treatment has to be done accordingly.
See, the most common referrals from eye specialists I get is they have some sorts of immunological problems in the eye. They do a Mantoux test or a IGRA, and they say, Ki, you go take a course of anti-tuberculosis. So what's your take on that?
If the tests have come out positive, yes sir, I don't see any problem with that. But
These are not confirmatory tests. See, Mantoux test and IGRA is just telling you that TB bacilli is there in the body.
It would
but
even
the
be
eye specialist is thinking that TB bacilli is probably causing some inflammatory problems in the eye.
No,
that is why you need to take an anti-tuberculosis.
Since it is a multidisciplinary thing, I don't think that should be done at all. I mean, unless and until you confirm the diagnosis. Yes, if you have sent a sample of the vitreous or aqueous is another thing.
Just like pleural effusion. Pleural effusion, we think it's more of a immunological problem than a seeding of the bacilli. Similarly, they have a red eye, some inflammation. They have tried to find out all the causes. They have not found. They think if the Mantoux or IGRA is positive, let us give a trial of anti-tuberculosis for 6 months. Maybe that inflammatory response will go.
I don't think that is the right way to go about it.
Anyway, okay. So next, Amitabh, he would like to talk something about TB and HIV.
Good afternoon. At the outset, I must thank Dr. Samuel and Dr. Sunita for organizing this, because with so many learned clinicians all on the same platform, this looks quite sumptuous already in terms of the discussion. In fact, today is World TB Day, so probably that was the reason for which you have been moderating. But what is important is, many times we see that we start ATT without doing viral investigations. So it is very important that every case diagnosed as TB must be investigated for I, B, C, and if at all, for other. Sometimes, if there is a sexual history exposure, then must investigate for all that. I see a lot of torch profile positive, especially if I take a history of exposure and find out, because very often you find they are all immunocompromised. So what is important is that when you start ATT, you should not wait for ART unless there is certain degree of associated complications. So you can wait for maybe maximum up to 2 weeks, but start ART within 2 weeks. If there is some kind of a intolerance, can wait up to 4 weeks. In a meningitis, maybe wait beyond 4 weeks. But what is important is that any case of TB should be started on ART within 2 weeks. And what is important is that you don't have to wait for the level of CD4 count. Once it is positive, start the ART. So if it is less than 350, if it is less than 200, then maybe you will have to think of what kind of ART you have to give. Because these days we generally give it the lamivudine, we are not using zidovudine anymore. We are using the dolutegravir. So I'm not going to speak on the first line ART drugs, but what is important is that you need to increase the dose of dolutegravir, maybe 50 milligram twice daily, if the patient is on ART, on ATT also. And at the same time, what is important is this IRIS concept, the immune reconstitution inflammatory response or the syndrome, that concept probably at present is not getting too much of acceptance, because the current ART drugs are quite safe. When it started in the 80s, 90s, and maybe till about 2005 or 8, iris was quite a big discussion in most of the meetings. But of late in 2025, iris is not much. We don't see also too much of it unless the CD4 count is less than 50. Because opportunistic infections come once it is less than 200 or less than 50. So in that respect, these are the few points I wanted to make.
So in the National Tuberculosis Eradication Program, it is mandatory to test all TB patients for HIV and diabetes. So you counsel the patient and get it done. That is mandatory. Okay. Next, Karthik.
Thank you. Thank you.
He had some presentation. Sorry, I couldn't. Didn't know it. You can go ahead, whatever you want.
So basically, I will speak about tuberculosis and sarcoidosis. These two are strong medical mimickers. So before you pinpoint a diagnosis, you must exclude sarcoidosis because they strongly mimic each other. It is very difficult to really pinpoint whether it is a TB and sarcoidosis. So there are few salient features in case of sarcoidosis, and there is no single gold standard method to confirm the diagnosis of sarcoidosis, but biopsy from the targeted sites showing non-causating granuloma is a reliable indicator. Other supportive tests like increase in serum calcium, urinary calcium, serum angiotensin converting enzyme, and if there is a bulk fluid analysis showing increase in CD4 plus and CD8 plus ratio more than 4, and when there is a TST, tuberculin test negative, then you can say this is a case of sarcoidosis. Because sarcoidosis and tuberculosis, the treatment are very different. So it is always wise to confirm the diagnosis before you jump into the treatment. So whenever you are evaluating a case of tuberculosis, if you don't find any clear-cut answer, always suspect tuberculosis. Always suspect sarcoidosis. And you can wait and watch because most of the time the sarcoidosis, the patients are asymptomatic. So in this context, I will always say whenever two patients coming to you with similar set of symptoms, radiological imaging profiles are similar, then you evaluate both simultaneously and exclude tuberculosis before jumping into sarcoidosis. And ma'am, I would just ask one question. Most of the clinicians over here, they are sending Mantux and IGRA both at a time. What is your take on this? They are sending both.
Like Mantuk and IGRA are not wasted tests, but they have to be wisely advised, taking into consideration the clinical condition of the patient, for what is he presenting and what is the age of the patient. Suppose the patient is BCG vaccinated, Mantux may come positive, but IGRA will not come positive. Okay, because the reagent which is used in Mantux is protein derivative from the mycobacterium, but IGRA uses typical mycobacterium protein that I told in my slide. That is CFP10 and ISAT6. So those two proteins are used. So it is very specific for Mycobacterium tuberculosis. So if IGRA comes positive, then the patient is definitely having Mycobacterium tuberculosis. But having said that, both Mantux and IGRA will only tell that it is a hypersensitivity reaction. The patient may have had a Mycobacterium tuberculosis infection in the past, but it will not say that it is an active infection. So those two tests is an indirect indication of tuberculosis, not an active indication of tuberculosis.
They are ordered simultaneously, that is what I mean.
They have to be ordered simultaneously. They have to be ordered because I told you, IGRA positive means MTB positive, whether now or in the past, but Mantoux, it could be because of BCG, could be because of non-tuberculous, could be because of Mycobacterium tuberculosis. So that is why IGRA also has got a superior specificity over Mantoux when you compare both. I think that.
The CBNAT is different. IGRA is a sophisticated version of MANTU. So MANTU is for poor patients, those who cannot afford, and IGRA can be for richer patients. CBNAT is...
IGRA is more sensitive.
CBNAT.
IGRA is more sensitive for mycobacterium tuberculosis.
Yes, obviously.
But
CBNAT is different.
BCG, if patient has taken BCG, Mantoux may be positive.
Mantoux will be positive. That's what ma'am is saying. Yeah, because IGRA is a sophisticated version of MANTU, as you know. CBNAT will pick up. No, CBNAT is different. CBNAT is a... What ma'am is...
Okay.
Now, what Dr. Vishal, let me clarify one thing. MANTU and IGRA, so they will suggest latent infection, patient has been exposed to, but CBNAT, cartridge-based nucleic acid application test, that will detect the mycobacterium. So that is obviously, more sense.
Okay, anyway.
So, when suppose now we have a patient, already we've done a Mantoux and the IGRA, and both of them have been negative. But still we see, as clinically, we are quite serious that it is a positive case. In that case, what next?
Yeah. See, that is why I told Mantoux, IGRA, TB culture. If it grows in TB culture, it is active tuberculosis. If it does not grow in TB culture, then maybe some latent infection is there. That is why it has come positive. No. That is why I told, CBNAT, CBNAT and TB culture. CBNAT will give you a result in 1 hour. TB culture will confirm whether it is TB or non-tuberculous mycobacteria. Non-tuberculous mycobacteria will grow in 10 days or maybe 5 to 6 days. The blood culture which I showed, it grew in 4 days. So because it was a non-tuberculous mycobacteria. So there are certain non-tuberculous mycobacteria which are rapid growers. It will grow in 4 to 5 days, and we will do the ID and AST.
See, clinically, radiologically, you should have a high degree of suspicion. And then only think about the other investigations. Anyway, Pritish, your take on TB and lymphoma, whatever you want to say.
So in our clinical practice, most of the patients, those who come to us, mainly those with hematological malignancies, complain they usually have fever, anorexia, weight loss, lymphadenopathy, and which is also a common clinical manifestation of any tuberculosis also. So differentiating between these two becomes very difficult, and in most of the cases, whether the patient is a case of leukemia, the blood investigation usually helps in diagnosis, but in lymphoma patients, we have to get some tissues from the lymph node. But in many cases, patients before coming to us have some test report with them, that is they most of the time they have a FNAC report from the cervical or axillary nodes, and which shows reactive lymphoid hyperplasia, something like non-specific things. So I want to give a message to the audience that whenever you want to do the differential diagnosis of any lymphadenopathy, excisional biopsy is the most preferred diagnostic test, then incisional biopsy, then core biopsy, and always avoid FNAC. Because even in tuberculosis also, one publication is there which has showed that in case of TB, FNAC has a sensitivity of around 18 to 20%, and lymph node biopsy has a sensitivity of 96 to 98%. So even if it's a case of tuberculosis, you will also not miss it if you do a biopsy, preferably excisional biopsy. And in lymphomas, and even many cases, some people have a tendency to, after a sort of, tends to start steroids after a short course of antibiotics if patient is not responding and nodes are not resolving. So if the patient is a case of tuberculosis, it will flare, and if the patient is a case of lymphoma, after a short course of mild response, it will progress and proliferate in a more aggressive way. So before planning any definitive treatment, if the diagnosis is not finalized, please prefer an excisional lymph node biopsy. And in some cases, the granuloma matter has already been discussed by Madam Rekha ma'am, that tuberculosis usually have they have this granuloma picture in the histopathology, and some lymphomas also have this granuloma in the histopathology. So commonly the Hodgkin lymphoma is a variety which also may have granuloma during the presentation, and the main crux in the diagnosis that both the lymphomas and tuberculosis in their histopathology finding, they have inflammatory background. Especially in the Hodgkin lymphoma, the population of the malignant cell is less than 10%. So the chances of missing a malignant cell, that is a RS cells, is very, very easy. It can be easily missed. So if we try to get a larger tissue, the chances of missing them is minimized. So that's why we have to prefer excisional biopsy rather than an incisional biopsy and than the core biopsy whenever possible. And I have to share one to two instances. In one patient, one 25-year-old male presented to us with lymph node in the cervical region, small lymph node around 2 centimeter in diameter, and the core biopsy was done before coming to us, and it was reported as lymphoma and immunohistochemistry. This was in another institute, and it was reported as T-cell lymphoma. And when he came to me, the time gap between the biopsy and IHC and presenting to me was around 3 to 4 weeks. And I saw that the T-cell lymphoma are usually aggressive, and the patient did not have that aggressive clinical picture to match with the T-cell lymphoma. So we had to take a second opinion. We did an excisional biopsy, and it showed presence of granuloma. Although it was AB negative, but matching with the clinical scenario, he was given pulmonary. We took an opinion from the pulmonary medicine people, and they told to give a trial of ATT. After the ATT was started, within 3 to 4 weeks, the nodes started dissolving, and he was escaped from getting further in any chemotherapy. So that's why the excisional biopsy was very, very helpful in this situation, because otherwise he could have landed in getting chemotherapy and must not have responded after that, and could have suffered all the other complications of chemotherapy. In another situation, recently only last month, one patient, 35-year-old female, came to us in the OPD with lymphadenopathy in the cervical and axillary region, and some in the hilar region also. And she was also having fever, anorexia, weight loss. And when I heard about this complaint, I told her to come here so that we can do a biopsy. But when she came here, she gave a history that 6 to 8 years back, she had tuberculosis. He had taken ATT, and it was responded, and it was a proven tuberculosis. And in the family also, 4 to 5 people are also having tuberculosis. I discussed with sir, and we started ATT without any further any invasive procedure, and I got information after telephonic communication that she is doing well. And in another scenario, a young patient presented with cervical and axillary and mediastinal nodes, and actually the size of the nodes in the cervical and axillary was very small, so that and FNAC was done from those nodes, and it was inconclusive. And getting a core biopsy from the mediastinal side was difficult radiologically also. So in that situation, he was given empirical treatment with antitubercular therapy. But after the patient started on ATT, there is no sign of improvement, and the patient ultimately landed up in emergency with presence of superior mediastinal syndrome. And at that point, the mass became accessible through for a biopsy. So a CT-guided biopsy was done, and Hodgkin lymphoma was diagnosed, and the patient survived after that diagnosis. So patient may present with many different challenging situations. In another case scenario also, patient had multiple lymph nodes and pancytopenia, and diagnosis from the lymph node was not possible because of the small size of the nodes, and RS cells were found from the bone marrow, and Hodgkin was diagnosed. And these are also published from one of the central institutes in India. And similarly, this TB and lymphoma most of the times gives us challenging situation, and depending upon the clinical findings, and we have to choose to get as much as tissue possible for a better diagnosis when we have to differentiate between TB and lymphoma?
See, any lymph node which is accessible, first thing is do a FNSC to exclude AFB. If AFB is positive, you know it's tuberculosis. There is no point doing a FNSC there. Yeah. Then go in for excision biopsy. If you don't find AFB from the FNSC, then go in for excision biopsy. The other part which Sushant and Karthik said, if you have confusion between tuberculosis and Crohn or tuberculosis and sarcoidosis, first treat tuberculosis, then think of immunosuppressors. Okay. Very much there. Now CBNAT, we do a aspiration and send it for CBNAT. Okay, very high sensitivity. I showed you 50-60%. Okay, now we have Dr. S.N. Mahanti, who was a little late, so we'll ask him to give his comments coming here on the dais, please. He'll be talking on TB and infertility, and then we'll take up Sucharita here. Okay.
Good afternoon, everybody. I've been assigned to talk about the tuberculosis in infertility. In India, there are most of the prevalence of tuberculosis in infertility is almost 60 to 70%. So by the time the patient comes to us for the treatment of infertility management, we always examine the patient, the female patient as well as the male patient. So whenever the female patient come to us, we examine what are the routine investigations, but we never come across the patient that patient is having tuberculosis. But when the patient comes to us with infertility management, then the patient comes usually may have pain, may have irregular bleeding, may not be present to us that I have some typical sign symptoms of tuberculosis. But when you investigate the patient, then the patient, we diagnose the patient by doing certain investigation. Whatever the normal routine investigation we do for the patient in case of infertility, I don't think we usually get patient infertile. So normally after the normal investigation, we do diagnostic hysterolaparoscopy, which is most important, rather than whatever the normal investigation you do, like CBC, then CVNAT and whatever, all these things, we don't do. But we do normally the investigation of diagnostic hysterolaparoscopy for the female patient. But male patient is semen analysis, which we may or may not get infertility. But in case of female patient, whenever we do diagnostic laparoscopy, there are almost 60% in our country, the patient is having genital tuberculosis. That is maybe very active or may not be active. So the mandatory thing in case of diagnostic hysterolaparoscopy we do is biopsy of the endometrium of the uterus. Because here the maximum cases of, if you go for biopsy, madam might have come across in case of tuberculosis, in genital tuberculosis or infertility, in India, almost 60 to, earlier it was 60%, now it is more than I think 70 or 72%. So endometrial biopsy, hysteroscopic endometrial biopsy, most important for diagnosis, which can be diagnosed by histopathological. Then after that, after diagnose the patient for tuberculosis, we usually give the patient for the treatment for, at least for therapy for 6 months. The regime, whatever you know, that is 2 months for 4 drugs, then another 4 months for 3 drugs. So, 4 drugs for 2 months, and yeah, 3 no sir, INH rifampicin for 4 months.
Now the national program is...
Sir, I'm not talking about this thing. I'm talking about the genital tuberculosis.
Genital tuberculosis also is same. National program is now 3 drugs in the continuous medicine.
Okay. So this is our diagnosis, and once because most of the patient, they come with the typical of laparoscopic tubercular mass or whatever, this typical tubercle, once you put a laparoscope, then that is an advanced stage. So for that, whatever sir says, we can give the treatment for this with 6 months, or if it is very severe, you can go for 1 year also. So these are almost in the management of tuberculosis in infertility. So this is overall, I told you. A diagnosis and all you might have discussed with
I'll make one comment here. I'll make one comment. I mean, this is a question to the lab people, lab experts. In fact, if you remember Dr. Sunita, we had long before, maybe about 5-6 years back, before COVID, there was a case used to present to us 3 times. It was given AFB positive. We started ATT, patient did not respond. In fact, sometimes this AFB positive need not be for Mycobacterium tuberculosis, it could be for Hansen's. So the testing has to be done for the Mycobacterium leprae at 4% and then subsequently the 20%. So that is very important. Again, the clinician has to take note of it, that this patient, we started ATT, patient didn't respond, then finally a biopsy was done in Ames, it turned out to be Hansen's. The patient finally responded to anti-Hansen's treatment because, so that lab people have to be, they have been sensitized about it. And this is something I wanted to bring to the notice of the audience. Thank you.
Another example I can give you for one infertility patient of our, in our faculty, department. One patient had come to me. I had a good experience with that patient. The patient came with the mass in the abdomen. So during that time, we didn't go for laparoscopy first, but now it is mandatory for laparoscopy and hysteroscopy. Then I opened that patient. When I opened the patient, then there is entire thing, mesh up, a tubercle with all adhesions in the pelvis. And I treated that patient for, I did the tuboplasty because all the tubes are blocked. And I did the tuboplasty. After the tuboplasty, I gave that patient for 6 months regime of anti-tubercular drug. And the patient came to me, after 6 months, the patient came to me with conceit. So that was a very good, I did with active tuberculosis. I did the tuboplasty.
One final question to our moderator, because not a question, in fact, it is something which he has been harnessing on. These days we don't treat only the manifest TB. We treat also the latent TB, especially in HIV patients.
I'll talk to you about
Probably he is going to.
I'll talk to you. Okay. I just had a patient of primary infertility. Under workup, the endometrial biopsy came positive, so she came to me for completing the treatment. She has just gone back completing 6 months, and I said you can go ahead with your infertility treatment, artificial insemination. Okay. Anyway, the last panelist, Dr. Sucharita, she will.
Regarding this order, sir, one more thing, that regarding that any ART, I mean, in vitro fertilization ART you do, you have to be 100% sure that patient is not having any genetic defect. Otherwise, baby and mother will suffer.
That is the reason she probably underwent an endometrial biopsy or somewhat.
Yes, exactly.
It was positive and she took up. The last panelist, Sucharita, will talk to you about some nursing issues.
My topic, it is given by sir, that is the challenges in the receipt and transport of TB sample and training of personnel. So it is very complicated when the consultant, clinician and in between the lab, the nursing personnel are holding such a serious responsibility for patient. A sample should be collected and should be transported by the someone else. So this is a multidisciplinary sector where the nursing personnel are always working. Now here I want to tell that some sample collection, now just few challenges are here. Then after, during when they are started to collecting the samples, few challenges are coming, and post also. So when the patient, the clinician is giving the advice to the nurses that the sputum culture has to be done, then nurses are giving some kind of education to the patient, and which is very important. If the education or counseling part has been done by the clinician, it is very easy to nurses to collect this sample. But most of the time, the nurses are going to collect this sample in the early morning, where patients sometimes are refusing that early morning is my sleeping time, don't disturb me. So such kind of refusal sometimes we are getting, that is the most challenging. And the patient age, where the pediatric patient we are getting, where the sample has to be collected, and sometimes the aged patient we are getting, where sample has to be collected. See, these two segments, the most of the nurses' challenge is coming to collect the samples. Now I'm coming to when the sample has to be collected, how sample has to be collected, whether the patient will wash her mouth, or without washing the mouth, they will give the early morning samples. Second issue, the nurses are always taking a challenge, how much I have to collect these samples. So, few times they are manipulating the saliva with these samples. So these two things, they need to identify properly which the sputum has to be collected, which is coming from the lungs only. So it should not be mixed with the saliva. Sometimes nurses are doing the documentation error. This is also challenge. The novice nurses, when they are collecting the ET sample, they are writing the sputum. So when the sample is landing to the lab, though the microbiologists are confused, if patient is in ventilator, how sputum is coming. So these all are the challenges for the novice nurses and the nurses, where it is really required the training program. Now, if I am talking about this suggestion or solution for all such challenges of the nurses, first things we have to need the training part for all the nurses, which the ma'am already spoke about. Every nurses should go to the lab, and at least the collection of the sample, it is very much required. Patient education definitely required if the screening has been done from the consultant or clinician, that the identified the sputum sample has to go. So clinician also may have done some counseling to the patient about this, how to produce the sample, because sometimes the production of sample is not there. Patient is producing with the dry cough, and such cases taking the sample from the patient is very difficult for the nurses. So another one, I will request our lab to standardize the process, how to take, when to take. If we are making the standardization of our process, so we can train our nurses, and every nurses will send the sample in same manner, and definitely quality control of the sample, it needs to be there in the lab sector. Whenever the sample is going in proper time by the our GDA or PCA landed up to the lab, quality control has to be checked by the lab personnel, where we are can improve our quality as well as sample collection. So this is I will request all the nurses to get these take-home messages, and our Sunita ma'am also give some standard of sample collection, especially for the TB and the quality control in the lab. I think that we can improve these things, sample collection from our end. Thank you so much, sir.
Thank you, Sucharita. So before I end, a few things I would like to discuss. There are some special situations in our hospital because it's a super specialty hospital. So a lot of CKD patients. So there your anti-tubercular dose has to be adjusted. The ethambutol, the pyrazinamide dose has to be reduced. Second, we are working up patients for transplant. So that is where every transplant patient has to undergo Mantoux test and EGRA. And if they are found positive, they have to be treated for TB preventive treatment for 3 months rifampicin INH. So that has to be mandatory. And
I just want to ask her. Just you told about if any transplant patient is for pre. If Mantoux and IGRA are positive, they need to be treated?
Yes. for 3 months. That is called TB preventive treatment.
So
Otherwise, if you give immunosuppressive, they will flare up and die.
No, on the basis of IGRA and Montox, they need to be treated.
Yeah, because they are latent TB. We call it latent TB.
So this is not specific. This is like past.
Whatever it is. But if the bacilli is lying dormant in your body and you give immunosuppressive, the TB will flare up. And we have already experienced this. One of our transplant patients, a senior doctor, died within 15 days after transplant.
This is a new thing, sir, because in our...
this is not standard. This is standard.
We have, this is for new for me. I have not...
This is new. It has come out in November 2024, NTEP guideline. Okay.
And for 3 months.
3 months. Rifampicin, INH for 3 months. Actually, they are, I tell you, emergency transplant, you have to go ahead with all the risk. But if it's elective transplant, do a MANTU, do a IGRA. If it is positive, give them rifampicin INH for 3 months. Previously, it was INH for 6 months. Now we are giving rifampicin INH for 3 months.
Which guidelines and from which data?
I'll send a copy to you. Don't worry.
I think Dr. Samisar has rightly said, in fact, this concept has come since last October, November. And this is a national program because they want to eradicate TB by 2025. So they say that it is not only latent TB you have to treat, you also have to treat all latent TBs, especially in immunocompromised individuals. Wherever the IGRA and the Montox are positive, and that's the course to be. I think this is something for all of us to go through. This is for all immunocompromised individuals. So, see, consensus has not come. This has come only recently. It's a Government of India direction. Government of India direction.
See, we are a transplant center, liver and kidney. So we need to know this, and we have to work up these things.
Consensus has to be there. Consensus has to be there.
This is the national program.
Yeah, this is a national program. This is a national program.
Okay. The second part is people, we get a lot of liver disease problem with cirrhosis patients with tuberculosis and all that. So you have to, because out of the 4 drugs, 3 are hepatotoxic. So there again, good monitoring and follow-up is necessary. And we have got...
One thing is you must avoid pyrazinamide. Because pyrazinamide is a hepatotoxic, it's the second line. We may not need it. So any chronic liver disease, anything related to liver, pyrazinamide has to
No, see, we don't say blanket brawl. If the patient is stable, he is not having any increase in liver enzymes, we give 4 drugs.
Pyrazinamide in chronic liver disease has to be avoided. It's a recommendation guideline.
But not in our national program. National program, you have to just monitor. You have to monitor if your enzymes are going up or your bilirubin is going up, then we reduce the dose.
Let's not dilute the message. Message is loud and clear. In chronic liver disease, somebody is delivery, no pyrazinamide.
I think these consensus have to be after the lunch between gastro and the pulmonary.
Okay. Then, and lastly, the final message, suspect TB clinically and radiologically, confirm the diagnosis by AAB, CBNAT and histopathology, TB preventive treatment for transplant workup patients, and modify regime for specific situations. Thank you. Thank you, all the panelists. Thank you, the audience.